Good afternoon. My name is Danielle Tate. I'm one of the TIPQC Maternal State Project Leads, as well as a maternal fetal medicine physician at Regional One Health in Memphis and an associate professor at the University of Tennessee Health Science Center. Today we're going to be discussing part 3 of our TIPQC Health Equity Conversation, Addressing Injustices in Maternal Care, a Call to Action. I have no conflicts of interest to disclose. This talk today is going to encompass 3 key concepts. The first is the facts on maternal mortality. Next, we'll move to the root causes of maternal mortality. And finally, we'll end with a call to action. What can we do? So first, let's dig a little bit deeper into the facts on maternal mortality. The United States is an outlier amongst all of the other developed nations in not a good way, but a bad way as far as how high the rates of infant and maternal mortality exist today and continue to increase. Currently, the infant mortality rate is 5.8 deaths per 1,000 live births. A pregnant woman in the United States is 3 times as likely to have a maternal mortality or morbidity in pregnancy than a pregnant woman in our neighbor to the north, Canada. Tennessee, unfortunately, ranks among some of the worst states as it relates to infant and maternal mortality in the United States. It's ranked 33rd in maternal mortality and 42nd in infant mortality. In addition, the opioid epidemic, the lack of Medicaid expansion, and poor health behaviors, on top of preconception health concerns, all contribute to these rates rising on an annual basis. Annually in Tennessee, a little over 200,000 women live in a maternity care desert, meaning an area where they do not have readily access to good health care or even adequate health care throughout their pregnancy. In January 2020, the NCHS released their first national data on maternal mortality in the U.S. in over 10 years. And here's what they found. They found that maternal mortality rates in the U.S. had risen significantly to 17.4 maternal deaths per 100,000 live births versus 14 per 100,000, which was seen in 2015. It also noted the wide ethnic and racial gaps as it relates to maternal mortality, with non-Hispanic Black women topping those rates at 37.1 per 100,000 deaths in live birth comparison. Maternal mortality rates in women over 40 as well were noted to be higher and 8 times more than that of a woman who was pregnant at the age of 25 or younger. In addition, they noted that there was an increase in the mortality rate partly due to the fact that reporting has increased over the years. When we compare the maternal mortality rates of the United States to other developed countries, we can see that that rate not only supersedes, but at times doubles or triples the rate of other developed countries such as France, the UK, or Australia. When we look at the availability of having skilled health staff across the world, we can see even with the United States having consistent availability of this staff throughout the states, we still rank higher than other developed nations. So it's really important to understand when death is occurring for women in the time period of pregnancy and the postpartum period. And interestingly enough, it's about equal during pregnancy, during the time of birth, as well as up to a year after delivery. And we really need to focus in on that third of patients in that year after, because most times these are the patients that are either lost to care or so focused on taking care of family that they ignore their own health. Our Maternity Mortality Review Committee put out data recently looking at our statistics in the state of Tennessee, specifically in 2017 and 2018. What they found was there was a total of 160 deaths related to pregnancy. And of that, 44 deaths were actually specifically related to pregnancy, which those deaths related to cardiac conditions topped the list. In addition, those that were not related directly to pregnancy totaled about 102, and the leading cause there was an acute overdose from an illicit drug. Also noted was that Black women were 3 times more likely to die related to pregnancy than their non-Black or white counterparts. In addition, 44% of those deaths had some substance abuse disorder as a contributing factor, and nearly half occurred in rural areas, which brings us back to the point we made earlier about a lot of patients living in healthcare deserts. In addition, the Maternal Mortality Review Committee noted that 81% of the deaths that occurred during this time period were considered preventable, with about a third of them being a good chance and about 44% having some chance of preventing death. A third or so occurred greater than 42 days after giving birth, and it was noted that those patients with lower educational level was associated with a twofold increase in maternal death compared to their counterparts. Non-Hispanic Black women were 1.4 times more likely to die within a year of pregnancy than their counterparts. When we look at contributing factors that were related to those pregnancy-associated deaths, we notice that substance use disorder topped the list, occurring about a third of the time in relationship to the death. Other contributing factors, when we put into play things like the patient and her family, the facility, the provider, we saw that about 40% of the time, the patient or family was a significant contributing factor to the death. And a lot of that contributed to lack of education, lack of resources, more than anything, as well as providers and the system and the community as a whole. And I put this slide here just so that we all recognize that we can't really point fingers and blame. It often is multi-layered as to the reasons why a mom would pass away at some point during her pregnancy experience. So now that we've discussed the facts behind maternal mortality, let's move on to the root causes of why a lady would pass away during the pregnancy period. There are a myriad of causes, but typically what we focus on are our top ones, and those include things such as cardiac disease, which usually tops the list, hypertensive disorders, as well as hemorrhage and sepsis. In addition, when we break down causes of maternal mortality by race, we can see even with the three races here listed, white, Black, and Hispanic, still hypertensive disorders and cardiac disease top the list of causes or etiologies of maternal deaths. According to our data in Tennessee, what are the primary pregnancy-associated maternal mortality causes that we should be discussing, that we should be focusing on, that we should be trying to either correct or prevent? It's a myriad again. We can see things such as venous thromboembolism, hypertensive disorders, preeclampsia, coagulopathies, complications after delivery. But what tops the list in Tennessee? Preeclampsia. We can see with any of those 2 to 4 times more likely of a risk of having maternal mortality if these are present. Obesity is our next cause, but we have to think of that more as a root cause that can then have this growth of other fallout or complications related to obesity, things like gestational diabetes, cardiomyopathy, preeclampsia, and what brings us here today to talk about maternal mortality. So independent of everything else that could be going on with the patient, obesity in itself is a risk factor. Even after correcting for obesity, Black women still have an elevated risk of certain things. Those include stillbirth compared to their white counterparts, type 2 diabetes after having gestational diabetes, and higher cesarean rate complications. When we look at disparities based on education, what we see is that as we move across the spectrum of more educated, we see that those rates of maternal mortality decrease. However, when we compare races, Black to non-Black, we note that even with higher education, Black women are more likely to die during childbirth in the pregnancy period. Delving further into racial inequity, the Maternal Mortality Review reviewed the data from 2017 to 2018 and noted that in that time period, Black women were 4 times as more likely to die while pregnant or in childbirth, and even the postpartum period up to a year. The Tennessee Maternal Mortality Review Committee gathered information on racial inequity as it related to pregnancy-related deaths in 2017 and 2018. And what they found during that time period, 46 Black women were noted to have died during the pregnancy period or the postpartum period up to a year after delivery. Of that group, 4 in 10 women were determined to have a pregnancy-related death. 63% of these pregnancy-related deaths were those that occurred 1 week or more after the time of delivery. So in that postpartum period where we know healthcare is not its best. It was also noted, as we stated before, Black women were 3 times more likely to die from pregnancy-related complications than white women. And the top causes for the deaths in this group included heart disease, preeclampsia and eclampsia, and embolisms such as VTE, DVT or PE, infections, and homicide. Interestingly enough, 100% of these pregnancy deaths were determined to be preventable. When we look at disparities across the nation, so we look at states that have low pregnancy-related mortality ratios, so not many deaths per live birth. It's important to note that even in those states that feel they're doing well as it relates to maternal mortality, there still needs to be an addressment of the gap between the races and the outcomes. When we look at perinatal complications, it's important to know that minority races have experienced higher rates of complications than compared to their white counterparts. And those things include things such as intrauterine growth restriction, preeclampsia, preterm birth or preterm rupture of membranes, gestational diabetes, bleeding, cesarean birth as well. When we speak specifically to Black mothers, they are more susceptible to life-threatening pregnancy complications than their counterparts, even when they have high socioeconomic status, they are educated, and they have access to care. In the photos, you'll notice 4 very successful, highly educated, very affluent, financially stable Black women who all had complications during their pregnancy. We know Beyonce with preeclampsia during the pregnancy with her twins, Serena Williams, who had to fight to be heard because she had a pulmonary embolism during the postpartum period after delivering her daughter that went unnoticed. And as a matter of fact, healthcare workers told her that she was overreacting to routine pain. And the 2 photos at the bottom represent Dr. Shalon Irving and Dr. Shanice Wallace, both who passed away days after delivering due to complications of preeclampsia that went unnoticed. Psychological stress, believe it or not, plays so much more of a role in maternal mortality than we give it credit. We note that non-Hispanic Black women are significantly more likely to experience the following due to psychological stress: preterm birth, hypertensive disease in pregnancy, small for gestational age births, as well as a myriad of other complications. What we do know is that healthcare disparities by age do increase as a woman ages. So much so that a Black woman who is 30 years or more in age is 4 to 5 times more likely than her white counterparts to die during pregnancy or the postpartum period. Maternal mental health and substance use disorders definitely deserves a seat at the table of etiologies. It is one that I feel doesn't get the credit or the light that it should as it relates to maternal mortality. It's important to know that 1 in 7 mothers will experience depression or anxiety during her pregnancy or postpartum period. Maternal mental health disorders and substance use disorders affect at least 10 to 20% of mothers. Psychiatric disorders are a leading cause of maternal death in developed countries, both in how they affect adversely the physical health needs of mom, as well as more directly through suicide. It not only affects the live births, but it also affects those moms who have miscarriages or stillbirths, but unfortunately the data we have now doesn't accurately affect the gravity of the situation because we only take into account live births. Maternal health problems that are typically associated with maternal mental health include it being undiagnosed, because most of it is going to come in features that are not usually associated with mental health, but more associated with being a new mother. Things like fatigue, poor sleep habits, having a mom who's not really focusing on herself and her health, but more on the baby. And then there's the gender stereotypes that come with being a new mother. It's oftentimes expected culturally that a new mom will be able to handle all of these things with ease. So new moms are less likely to speak up in regards to how they're feeling. Poor physical health. Again, mom's gonna focus more on her new baby and her family than her own needs. You're gonna see persistent and high risk behaviors, those including substance use, so things like alcohol or illicit drugs. You see an increased risk of obstetric complications and preterm labor in moms with mental health disorders, as well as these moms are less likely to care adequately for their own needs, their day-to-day eating, bathing, sleeping, those things they will tend to ignore because of their mental health issues. Lastly, these women are less likely to seek and receive the care they need, either during the pregnancy or the postpartum period, again, because culturally, one, it's expected that they should be able to handle these things on their own, as well as they are less likely to speak up in fear of being thought of as lesser than a mother if they bring these things to someone's attention. When we look at the recognized types of perinatal mood disorders we can see related to pregnancy, there are 6 main ones. Depression and anxiety definitely top the list, and what you'll see most commonly either worsening or presenting for the first time during the pregnancy period. But psychosis, obsessive compulsive disorder, panic disorder, and post-traumatic stress disorder also top this list. When the Tennessee Maternal Mortality Review Committee reviewed maternal mortality as it relates to substance use in Tennessee, what they found was that 34% of women, 34% of those pregnancy-associated deaths specifically in 2018 were related to a substance use disorder, and that was a main contributing factor to the person's death. 93% of those deaths that we saw were actually deemed preventable. When we look specifically at opioid use disorder, it is definitely a cause of many negative health outcomes for mothers and their babies, especially during pregnancy and after delivery. Opioid use has gone up more than 4 times among pregnant women, and we see this more and more as we go through these years, especially in years like now with the pandemic and all of the stressors that were brought on by such a big change in the world. What's also noted in women who have an opioid use disorder history is that infants can be born with breathing and feeding problems, as well as moms are at risk for opioid-related overdose. So all these together, we see that opioid use disorder in pregnancy can be linked to preterm birth, low birth weight, breathing problems for infants, feeding problems, as we mentioned, and then maternal mortality as well. When we look at maternal mental health and substance use disorder as it relates to our pregnancy-related deaths that we saw in Tennessee in 2017, you can see that those pregnancy-associated deaths, a much higher portion were related to substance use disorder. As well as looking at 2017 and pregnancy-related versus associated, we see the same thing. A good portion were related to our opioid use disorder, our substance use disorder, and mental health. Lastly, when it comes to etiologies, we're going to talk about the elephant in the room. The one thing that tends to make us a little bit uncomfortable, but definitely needs to be spoken to as it relates to maternal mortality. And that includes structural racism, provider racial bias, and patient mistrust in the medical system. When we delve a little bit deeper into racism, it can come in one of 3 ways. Individual racism, meaning discrimination by an individual on a race. Institutional racism, which includes policies, practices, and procedures that maintain a system of inequity, inequality, and inferiority for minority groups. And then lastly, structural racism, which includes the history and current reality of institutional racism as it regards access to care in institutions across the nation. Systemic racism is depicted just as you see in the picture. You have 2 individuals who outside of race should be equal but live 2 very different lives based on what they're provided by the systems they live in. The question always comes up, well, how prevalent is conscious bias? Well, I'll ask you the question, what percentage of OBGYNs do you think openly admitted to having conscious biases towards certain groups of patients? Believe it or not, 47%. And that's conscious bias, where they were aware of the biases they had when treating patients. But let's talk about unconscious bias. And to help you understand that more, let's define it first. It is a bias that we are unaware of and which happens outside of our control. It's a bias that happens automatically. It's usually triggered by our brain when we're making quick judgments and assessments of people or situations. It can be influenced by our background, our cultural environment, and even our personal experiences. It's important to know the key characteristics of unconscious bias. It's important first to know that it's automatic, and it usually doesn't associate with things like awareness, intention, control. There's usually no hatred or fear. It's just something we automatically do. It's oftentimes we forget about it, we don't realize we're doing it, or when we're confronted with it, we're denying that it's even happening. Unconscious bias are often associated with conflict in conscious attitudes, behaviors, and intentions. Generally, we hold unconscious biases in favor of our own group, in favor of people that we can relate to when it comes to the situation. Unconscious biases are malleable, and they often come with focus and commitment. When racism and racial bias in healthcare was studied, what was found was that physicians, nurses, and other healthcare professionals and institutions were shown to have implicit racial bias. And this was shown by way of patient reporting things such as undertreatment and underestimation of pain, providers not counseling appropriately on the contraceptive options, patients of color feeling like they were unheard or disrespected in the healthcare setting, poorer obstetric outcomes and GYN outcomes in patients of color, and lastly, maternal mortality in abortion and childbirth significantly higher in women of color. When we look at consequences as it relates to implicit bias, when a clinician has racial or ethnic implicit bias, interactions with patients are characterized typically by less involvement of the patient in decisions, worse patient outcomes, and patient satisfaction scores being significantly lower than expected. Despite our best intentions, Black women still are 4 times as likely to die as white women during childbirth with all the resources that we have. Minority groups receive lower quality health care. Pregnant women seeking access to life-saving maternal health services often face discrimination. And then we talk about perceived racism by patients. They can really sense that differential treatment by staff based on insurance status. They understand and recognize lower quality of prenatal care when we look at racism and how it's inserted into these situations, as well as doctor interactions being described as prejudice. And believe it or not, racial and ethnic disparities are associated with substantial economic impact, and specifically negative impact by way of loss, to the tune of $35 billion in excess healthcare expenditures due to racism and bias, $10 billion in illness-related lost productivity, $200 billion in premature deaths. And believe it or not, doing nothing comes with a moral cost that we cannot quantify in the very least. So lastly, we're going to talk about that call to action. What can we do? The first thing we can do is be aware of our own biases. We can do unconscious bias training with our staff, physicians and nurses included, doing training with the AMA, and doing a commitment to increase that cross-cultural competency that's needed in all institutions. And I want to bring note to this implicit association test that I encourage us all to take to see where we sit personally with bias. One very effective approach to addressing unconscious bias is the FLEX system. And it's tiered out in different layers of approach. We first start with focusing within, tune into our own emotions and how we project and how we digest what we see. Learn about others. Take the time to understand other cultures, other races, and their belief systems. Engage in dialogue. The best way to understand someone is to communicate with them. Ask open-ended questions. Listen more than you talk to really understand. And then expand the options. Brainstorm on solutions. Be flexible in how we approach people. Take that feedback that you receive and really build and grow and evolve on it to make that experience better. What's just as important is cultural competency. And this is a way of evening the playing field across all ways and all aspects in which we deliver care and we interact, by way of how we use languages and practices, our relationships, our customs. All those things factor into how we treat each other. But it's not an easy, simple, not to doing. It is a process to go from culturally incompetent to culturally competent. And you can see along the way, we go from being more self-aware to more aware of everything around us. And what we want to see is what we see on the right, and that's justice. We talk about equality, we talk about equity, but justice allows us to support all those in the system in a way that we can best support them so that no one has an unfair advantage. It is time to act. I think we can all agree. That elephant is sitting right here in the room, but it's going to take several layers of acting together to really reduce maternal mortality, and that's involved on the level of the patient, the provider, and the community. So we'll first talk about the patient. How can we optimize the patient's health? We can do that by reducing comorbidities, reducing the rate of obesity, optimizing conditions such as diabetes and hypertension, or even doing measures to prevent those from onsetting. Identifying complications during pregnancy that can be prevented or that could potentially lead to cardiovascular disease and prevent that outcome from happening. Know and communicate about symptoms and complications. Make sure the patients are aware of what to expect if something is not going right with the pregnancy. And then make sure that we're noting the pregnancy history every time we encounter a patient for medical care. When we address the social determinants of health, we're really trying here in the United States to line up with the Healthy People 2030 goal. And when we look at where we are now, the U.S. overall still has not met that goal in the three main areas of uninsured women, inadequate prenatal care, and poverty among the women. And you can see, even when compared with the United States, Tennessee's rates still top that of the United States. So we have a lot of work to do. When we address the social determinants of health, as with anything, there comes a variety of things that play into what we consider to be inadequacy amongst the different races. So things like educational disparities, food disparities such as food deserts, economic instability, transportation, neighborhoods, all those things play into these social determinants of health. So it is going to take us working together in many ways to correct the problem, or at the very least improve what we see. Despite all that what we know, Black women are still disproportionately at a lack of safe housing and stable housing, affordable transportation, insurance, and partner support. We move on to the provider level. What can we providers do? It's a simple solution, right? We're just going to make sure every pregnant woman has quality care throughout her pregnancy and for that 1 year postpartum. But is it really that simple? Likely not, but there are still things we can do to help improve the situation. First, we can help patients manage their chronic conditions. Communicate with your patients about the warning signs specifically when they have these chronic conditions present during pregnancy. Use the tools that you have to flag the warning signs early so that women can come and have adequate treatment in a timely manner. And then educating your patients on the risk of cardiovascular disease, whether it's during pregnancy or later in life. So what's our solution to this perception of racism? We want to continue to, or start, providing quality patient-provider communication. Continuity of care is important to build those relationships. Providing mutual respect and compassionate care as well. What we want to do is start practicing what we call cardio-obstetrics, using the team, all disciplines on the team, to provide that fluid, seamless care from start to finish for the patient. We start with our preconception counseling up into that long-term care following delivery. And that's not only going to involve the nurses and doctors, but it may also involve the pharmacists, the anesthesiologists, the social workers, and so on. So what can our hospital systems do to address this need? Standardization and coordination of care in response to emergencies. So making sure that everyone's prepared through things like protocols or simulation is going to help improve tremendously. Improving delivery of that quality care on a consistent and regular basis, both prenatally and in the postpartum period. Training our non-obstetric providers to consider their recent pregnancy history, or even those who care for pregnant women to understand the breadth of what it means to be pregnant. Implementing some protocols and quality improvement initiatives, especially in those facilities that serve the disproportionately affected communities. Identifying and addressing implicit bias in the healthcare. That is going to improve patient-provider interactions, health communication, and health outcomes. So what are the strategies do we have, and what we've proven to be effective is, first, we have to confront our own racism and our own prejudice we may have against other people, right? As well as expanding Medicaid. Let's expand healthcare coverage beyond those first few weeks after delivery so that we can address and treat patients appropriately. And also have a commitment to diversifying our healthcare workforce so that anyone who walks into our institution can feel comfort and relatability to the staff that works with them and cares for them. So we can see different levels where we can be a part of the solution and not the problem. Things like research, we can work with uniting the teams together, we can be an advocate, we can work to educate ourselves and others, we can partner with other organizations, and lastly, we can support the system and support the patients. And then we move on to community involvement. What can our communities do? What can be done on the state level? We've discussed it before. Extending that postpartum Medicaid coverage is key to allow patients to have access to care for longer. Because we've proven through this talk and many others that we can have complications that can be very much so significant up to a year after a patient delivers and sometimes beyond. Access and coordinating on the delivery hospital level to make sure that patients are receiving risk-appropriate care, supporting review of maternal death so that we can learn from the outcomes that we were trying to avoid, learn for those outcomes that are definitely not pleasant ones, instead of making it seem like something that should be put in the dark and never discussed again. Of note, the CDC has awarded a tremendous amount of funding to state MMRCs, which are your maternal mortality review committees, to support this endeavor of understanding better and improving outcomes as it relates to maternal mortality. In addition, updating our death certificate to really reflect what is needed to know, those critical key factors in the death of a woman during pregnancy and the postpartum period is key, so that we can better understand those factors and potentially address and improve the outcomes as well. In addition, it's important to know about Preventing Maternal Deaths Act of 2018. This act was set out to support states in their work to save and sustain the health of mothers during the pregnancy period, childbirth, and postpartum period. Its goal was to help eliminate the disparities that we see in maternal health and how that relates to the outcomes that we see, especially the unwanted ones related to pregnancy, including maternal mortality, and to identify solutions to improve healthcare quality and health outcomes for mothers and infants. So it's important to know a quick update about maternal Medicaid coverage. And the point of expanding coverage was to harness the immediate postpartum period, because women are at risk to having long-term adverse outcomes and even maternal death, as we've discussed throughout the talk. So expanding that care so that the primary care physician can care for the patient during this longer period of time. Beyond the immediate postpartum period is what is key up to a year. Currently, TennCare's postpartum insurance currently lasts only about 2 months. And we know that most women, as we've seen through the statistics presented in this talk specifically, die after this coverage period ends. Right now, there's a pilot program to extend coverage to 1 year that will cost about $19 million to the state. And this was proposed back in 2017 based on the number of preventable deaths that we saw that occurred during that year. Of good note, we've seen recent approval of the TennCare 3 demonstration, which means we are just moving closer to that goal of expanding coverage than we were before. So what else can be done? We can partner with our community, state, and national organizations, because together we're able to do more. We can address those barriers to accessing health care and help provide assistance. We can develop protocols for interpersonal violence screening. We can implement systems for mental health disorder care. We can implement education on implicit bias. We can provide consistent screening, assessment, and treatment for chronic illnesses, and increase knowledge and access to medication-assisted treatment programs for those with substance use disorders, and as well as access to naloxone, not only for patients, but their support system and our community partners. increase funding for inpatient and outpatient substance use disorder and mental health treatment for pregnant and postpartum women, and implement community-based education programs not only for patients, but for their support persons and for the community as a whole. And lastly, addressing food deserts. Thank you for your time, and I hope you enjoyed the information you've received today. My goal is that this conversation is not the end, but the beginning to making Tennessee a healthier and happier place.